I will give some more details about my roles as we get into the presentation. What I want to do today is not focus so much on the details of AI and machine learning as more on some general systems pieces. We are at a very big change point in our world. There are things that are happening in the digital space that most people don't see. And people are commenting on what they see, and they are not able to see how far things have moved. One of the reasons for that is that the data giants like Google and Apple and other organizations are keeping things behind closed doors as they refine and move things out. So AI and psychiatry, I'm saying the future is here, and I want to give you an update on current issues and opportunities. Oops. Okay. Robert Cloninger inspired me to put this slide up here. I was very impressed with his lecture yesterday, talking about his theory of personality and looking at the idea that as people, we are not wise enough yet. Our problems are simply that we haven't reached that level of ability to manage things. And with our current situation, as President Kamal said at the very beginning of this Congress, the world is facing a very terrible set of circumstances. Pictures like this are an example of how we start out with, if we're lucky, good minds and good relationships, and things happen as we move down the road of life. But we always have the opportunity of being solution-oriented, and that is the way forward. And the byline of this conference is From Unmet Needs to New Approaches in Psychiatry. I live in Canada, and it's our tradition to give a land acknowledgement. This is a picture of a dancer in the land close to where I live, so one of my neighbors in the Enoch Cree Reserve. And I want to state that I respectfully acknowledge that I live and work in Edmonton, Alberta, in what is called Bear Hills territory, on the traditional territory of Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, and Ojibwe, Saulteaux, and Anishinaabe nations, also known as part of Treaties 6, 7, and 8, and a homeland of the Métis people, who are the product of interaction from the early explorers in Canada and the Indigenous people, and they tend to speak Indigenous languages and French. My affiliations and disclosures, I have no conflicts for this presentation today, but I wear a number of hats. Mental Health Research Canada is Canada's non-governmental research funding agency, and I lead that organization. I'm the scientific director of something called the APEC Digital Hub for Best Practices in Mental Health. APEC is the Asia-Pacific Economic Cooperative, which is 21 countries in the Pacific Rim, about 2.3 billion people. I'm on the Global Leadership Council of something called the E-Mental Health International Collaborative. And if you're interested in digital health, I recommend that you all take a look at the website for this organization to have leading-edge webinars and convene a fantastic conversation specifically around digital health, including AI and machine learning. I also run an addiction center, a not-for-profit addiction center for men. It's an addiction recovery center in Edmonton. The place I work in is actually one of the top 3 sites for AI and machine intelligence research in the world. Leading edge, it's the place where non-supervised learning was first thought about and developed. And there's a close collaboration with DeepMind, and we have Alberta Machine Intelligence Institute, and I'm one of the members of the Management Advisory Board for that institute, part of Canada's cyber infrastructure. And I'm also locally at my university the Scientific Advisory Board Chair for our Institute of Neuroscience, Mental Health and Addiction. We have a great computational psychiatry group at the University of Alberta, and I put this up in the beginning because I'll forget to say this, and these are the people that work most closely with me at the U of A, and we have international associates, some of whom are at this meeting this week. So Russ Greiner is one of the founders of the Alberta Machine Intelligence Institute. Salvor Cloud is Canada Research Chair. Sud Adolescent is known to many people, a professor of psychiatry. Ximin Li is at the meeting today. Eleni Strulli, Osmo Zain, Matt Brown are computing scientists. Jake Hayward is a young emergency physician in academic medicine. Tony is a brilliant software engineer that's our postdoc. Another postdoc, Sunil Kalmadi. And then we have a couple of graduates, James Benoit and Jeff Sawala, who are now postdocs. So the three logos there of AMI, the Computational Psychiatry Group, and the Digital Hub for Mental Health are given. So at the meeting so far, we've heard a number of times that mental health is a key part of the global burden of disease. And Alan Young reiterated that in his plenary this morning, talking about depression, which is a major part of the burden for mental health. When we look at digital health going back a few years, we can see the world has changed very much. So in 2016, a viewpoint in JAMA, Machine Learning in the Profession of Medicine, just began the discussion. Time magazine, 2017, how robots are changing the way you see a doctor. That's probably a little too far of a prediction because I think today robots have still not changed the way you see a doctor. Harvard Business Review, just before COVID, I was in China when this came out, raised a number of problems about whether AI would ever make progress in health. And my comment was no. I put a line around adopting AI in healthcare will be slow and difficult. It's not. It's happening, and it's happening in ways that you just don't see. So the current system issues in psychiatry and mental health. Echoing other people at this conference, we have insufficient access to mental health care, assessment, and intervention. There just aren't enough services, and Alan Young this morning said that in the European domain, about 81% of people just didn't get access. There are not enough trained healthcare professionals and not enough funded support. We all know the health system is very expensive everywhere, especially in developed nations. Turkey is an example, ramping up costs all the time. Digital health technology offers a solution, and AI is actually implemented widely today. Whether we saw it or not in medicine, we were already well down the road for AI implementation, and COVID actually pushed us over the digital divide. Many physicians, not just psychiatrists, but many physicians had no choice but to adopt digital health, or they wouldn't be able to do their job and they wouldn't get paid. So a lot of people who really complained this would never happen, they started doing it and they found out there are a lot of advantages. It's very difficult for a physician to be late for a digital appointment, for example. There's some equity there that we haven't seen before. In our computational psychiatry group, we work on different things. So we work on the major index disorders in psychiatry, of course, leaning into neurology a bit. We use lots of different kinds of data. We use genetic data, imaging data, neuropsych data, human speech for natural language processing, and health records. And I have something to say about each of those kinds of data, because a lot of what we do is high-end neuroimaging analysis, for example. That's not likely to get very far in the health system unless imaging becomes really cheap and available to everybody. So we do a lot of techie science stuff. My interest these days is, we do a lot of that, but my interest in these days is trying to implement change in the health system by trying to implement AI and machine learning solutions, which can have instant impact rather than being like drug technology, 10 or 20 years away from implementation. Our goals are to improve diagnosis, prognosis, to develop clinical tools, and in the bottom in bold is streaming data analytics. And I'll say more about that. So looking back on my life as I get older, I think about when I first started working with computers, which was back in 1973. I took some time out of school, worked in the computer industry for a couple of years, and I realized that in 1973, society was already completely dependent on computers for doing mass calculations and communicating, for payroll, for all kinds of things. And I would see trucks moving around the cities in which I lived with data logos on that nobody recognized. There wasn't a Google back then. People recognized IBM and maybe the Digital Equipment Corporation, but there was a lot of background stuff going on. It's still a lot of stuff in the background today, but a lot of it is on the internet. So I'd say society has been dependent on computer technology since the 70s, and cultural acceptance has been progressing. The rewards have generally outweighed the concerns for the public. Nobody really complains about internet banking. Nobody complains about automatic processing of a lot of things. People have concerns about health data. And especially since the adoption of email and the internet, which many of our younger colleagues they just don't remember that. It was before they were born, and smartphones particularly. If you're interested in a look to the past, I recommend this book by James Bailey. It's only available in English, but it's a really good exposition of how things have changed. A computer used to be a person sitting in a room like this. Imagine all of these seats filled with people doing calculations by hand. That was an original computer. All that got replaced, more than anyone could imagine, by machines. Your smartphone in your pocket has more processing power than the whole world had in 1980. That's remarkable. So machine learning is a branch of artificial intelligence concerned with using computational models capable of learning patterns from data in order to make predictions. It's a very convenient 2019 definition, but it really demonstrates what is happening. In this diagram here, we have reinforcement learning, supervised and unsupervised learning, and all the different components and things that can be done, from image classification to fraud detection, real-time decisions, robot navigation, optimizing processes. It is all-encompassing these days. So what do we do with AI in the mental health care context? A lot of what we do is related to prediction. And I'm not going to go into any technical detail in this talk, but you will see receiver-operated characteristic curves everywhere if you look a little bit under the cover for machine learning or AI. And this is really something that derives from signal detection analysis from the time in the 1940s when people were trying to detect events with new technology like radar. Is this a real event or not a real event? Is it true or false? And as you develop a predictive model, you can see on, I'll just say on the left-hand side of the screen here, you have false positive rate and true positive rate. True positive rate sensitivity. And this blue line, as it pushes towards the top left-hand corner, indicates you're making better and better decisions. Your probability of making a mistake is less. So it's really the signal-to-noise ratio around predictive probabilities. And on the right-hand panel, you can see ROC curves generated by using different machine learning algorithm approaches. So this indicates that it's not one size fits all. Next door, there's a symposium. Some people are talking about deep learning. Deep learning sounds great, but it's not suitable for a lot of problems. So you have to choose the machine learning approach that fits the problem. And often it's trial and error. And often we'll put different machine learning solutions together in an ensemble to generate the best predictor. So I said we've done a lot of techie stuff. Here's an example. We had attention from a German TV station that wanted to focus on some work we'd done that was published in Nature Schizophrenia back in 2019, just before COVID. And here's the joke. It's Sunil Kalmadi is the man in the middle, and Russ Greiner is joking that maybe that's his brain. Towards artificial intelligence in mental health by improving schizophrenia prediction was the title. And we used brain imaging, something called multiple brain parcellation ensemble learning, quite a complex machine learning approach. Really good for generating predictive values, but not suitable for meeting with someone with psychosis in your clinic and trying to make a decision. These kinds of studies can give value in terms of a kind of reverse engineering approach. If you pick out things that correlate with this really high-tech decision, that would be a way to make simple predictions. So we're always looking at predictors that would be available to you in the clinic rather than having to do somersaults in a machine learning lab with neuroimaging. It's very interesting, it's good science, but it's not going to be translated directly to the public. We've moved more recently, this is a 2021 paper, and this is Jeff Sawala, now a postdoc with us, who actually starred in an award-winning movie. He's the only student I've ever had who's actually a movie star. And we use natural language for individualized identification of first episode bipolar disorder. So looking at language content, and this was done based on some standard databases that were available of interviews with people who are being assessed for bipolar disorder. I'll just put this up for credentialing. Most of these papers are high-tech machine learning papers. So the one there is, I'm not expected to read it, predicting pediatric anxiety from the temporal pole using neural responses to emotional faces. Here's an example of a machine learning study where we looked at predictors from brain, and we were actually able to identify the temporal pole as an area of brain that had not been focused on before, but it had predictive value. So we moved back into maybe we should look more closely at the neural models and see how the temporal pole is engaged. So in that case, machine learning revealed something that people had not seen before. There's a lot of stuff about diagnostic prediction. We looked at depression, suicide, autism, attention deficit disorder, depression, anxiety, and addiction. One of the papers in the middle is called Individual Prospective Prediction of Opioid Use Disorder. And for that, we accessed health records, hundreds of thousands of health records from a population of 4.5 million people. And we came up with a good prediction of the likelihood of somebody developing opioid use disorder. So there are lots of these papers. And I'll go into some detail, but I don't really want to dwell on a lot of them in any technical detail. So on the right-hand side at the top, you can see individualized prospective prediction of opioid use disorder. That's a recent paper. And on the other side, prediction of depression onset in middle-aged and elderly adults using machine learning and a database called the Canadian Longitudinal Study on Aging cohort. And this gets towards one of Alan Young's comments about we really need to start looking at the risk of depression and maybe moving into mild cognitive impairment and dementia in elderly populations. So it's possible to do that with big data. I don't often recommend reviews, but the review article in the bottom is useful because a group from Britain and the Emirates did a pretty good meta-analysis on performance of AI-driven technologies in diagnosing mental disorders, and they went through a number of different disorders. Moving on to something else we did, we had access to Pfizer data set for their depression trials. And we wanted to see if we could predict responses to venlafaxine. The problem is selecting an antidepressant is not easy. If you think about clinical practice for those of you who are psychiatrists, the probability of getting it right for an antidepressant is not very high. So for newer antidepressants, 37% of patients don't achieve a response, and 53% do not achieve remission following 6 to 12 weeks. So that's a big failure first time round. And the rule generally is if you fail to get the right antidepressant the first time round, the chances of a positive response decrease. So one of the issues about using AI and machine learning is people sometimes expect there's going to be perfect performance because it's a machine. And we forget that health professionals do not perform at a very high level in terms of getting it right. Psychiatry is complicated. And a lot of the time you'll prescribe a drug to a patient and there'll be treatment non-responsive. And it's very difficult to figure out what are the details. If you put yourself in your patient's shoes and you think, okay, you're going into the office and you have a choice of talking to your psychiatrist, who's probably very nice, or having a machine decide what your prescription is. Personally, I don't care. I want the better decision. And if the machine outperforms a psychiatrist, psychiatrists can still do the other functions of supporting me, but I want the correct drug choice. It's a health technology decision. So this is a very simple demonstration. This is James Benoit was the lead on this. We trained a linear support vector machine algorithm, had a holdout set accuracy of 69%. So 69% of the time, the machine learning algorithm would predict whether there was going to be a treatment response. It turns out that's better than the average psychiatrist. And these were simple measures. They weren't all obvious, but they're not that peculiar. So there were 26 features from the clinical trial data that popped out. This was from international trials. So one of the features was actually where you were from. One was ethnicity in terms of American indigenous status. There were 8 items from the Hamilton D, 3 items from MADRS, 1 measure of polypharmacy, and 4 lab tests that included creatinine and urine pH. A real mishmash, but that predicted the outcome. One of the things about machine learning solutions is you don't always understand why it's predictive. And it doesn't matter if it's causal. If it's simply a correlation and it helps you make the decision, doesn't matter if you understand it or not, if it gives you the right answer. There's a debate going on about understandable AI, and the more complicated the problem is, the more difficult it is to understand the solution. And these days, some of the programs, we'll talk about large language models in a minute, some of the programs we deal with are so complicated, you can't go back and, as we used to say, debug them because we don't understand how they work. I'm just putting a clock up here so I keep an eye on how much time I have. Okay. So there's an example of how a simple machine learning analysis with a restricted data set can give you a better outcome in terms of decision. It's an example. The review I mentioned, the question of equivalence of human decisions and AI decisions. How good is the machine for making a diagnosis? So these authors extracted data, systematic reviews of 852 citations, and they looked at the performance of AI models in diagnosing Alzheimer's, MCI, schizophrenia, bipolar, autism spectrum disorder, obsessive-compulsive disorder, PTSD, psychotic disorders. And it was all over the map, but the performance from those reviews were between 21%, that's not very good, and 100%, that is absolutely excellent. So it illustrates the potential. And one of the problems with getting a global view like this is the field is moving forward so quickly, demonstrations of success are probably going to be amplified in the future as people get things right in terms of providing the right kind of data. Here is one of our Canada research chairs, Cao Bo, who is, calls himself Cloud, looking at Alberta health data. Now, everybody who does big data studies wants access to health data. This study showed us, in fact, you don't want access to health data. I had a conversation with a young psychiatry resident this afternoon in the coffee area outside, talking about the way health data were built was not with research in mind. So, for example, in many systems, the code you use, the diagnostic code you use, and Alan was talking about this morning, often it's a code that's tied to billing. And so every physician will give the optimal billing code that's within the realm of what the disorder is, but will pay most money. It's just a natural thing to do. The problem is the fidelity between the code and what's wrong with the person is not there in the record. So just looking at billing codes, you have to also do some reverse engineering with what kind of drugs they were treated with. And we all know that antipsychotic drugs, for example, are not always used to treat psychosis. So there are symptom-related applications of drugs. In fact, UFAR and the CIMP have moved towards let's not talk about antidepressants, antipsychotics, and anxiolytics for that reason. So trying to decode a health data system that wasn't designed for research is a lot of work. And one of the things that's happened as we've moved across the digital divide is we started to ask questions about what we need for digital health and digital analysis. In fact, those questions are questions that are not just about digital. They're about how the health system works. So whether you're human or going digital, if you don't have the right data in a database, it's not going to help you. And we tend to look at archived data. And the health system will only give you archived data that's been processed and typically at least 1 or 2 years old. So you're not looking at today, you're looking at history, which can be illustrative but not helpful for you and I as a patient in the system. This was a study of nearly 700,000 people. And the algorithm was trained on 700,000 people, and then we had a holdout sample of about 175,000 to check the accuracy. And we used administrative records with ICD codes that were problematic. It's a good predictive model, but it's limited by where it is. We have rapidly developing health systems, and they have big potential advantages. I'm involved in a lot of international work, so I'm involved in building digital health for the Philippines, and we'll be there in late November, early December for a digital health launch. They have a real advantage because they don't have the health system that developed nations have. It's very difficult to disinvest in a system that's already cost millions and millions of dollars to build and has a culture that's built in. The data in the health system are not the data we need. And I'll make the argument later on that, in fact, we need streaming data. I know that Professor Chetan uses his health app on his phone, and he could show you information about what's happening with him today. Being able to harness that and bring those data in the clinic, including some mental health indices, would bring us a long way further. If you could see somebody's history in the office for the last 3 weeks, including activities and physical measures and some assessments, let's say PHQ-9, G87, quality of life scale, you'd have a much better idea of what you were dealing with than simply having an interview with somebody in the office. So there are big potential advantages ahead. Data access is a limiting factor, but it's limiting not just because we don't have access, it's limiting because we have the wrong data. When you see claims that AI and machine learning apps and different applications are really good, be skeptical, because these things have to be tested very well. The example I gave you with clinical trial analysis with the Pfizer venlafaxine trial, desvenlafaxine trials, we have the issue of efficacy versus effectiveness. Clinical trial data are not real-world data. That also came up in a couple of talks in the last few sessions in this meeting. And somebody mentioned in the audience that we really want real-world data. There's an obsession with accuracy and specificity when it comes to digital solutions. And I think it's really important to be practical. Better is better. Perfect is not necessary. If you have a system that performs at 55 or 60%, and you can move it up to 80%, that's a great benefit for patients. And that's a choice that should be made in terms of optimizing what we have. We may never get to 100% predictive accuracy, but we can get close. And the validity of predictive analytics with machine learning and AI is dependent on the data sets used for training and validation. You probably know this, but when you do machine learning analysis, you have a data set in which you train the algorithm, and it learns the predictors within that data set. And if it's overtrained, it will make perfect predictions based on that data set. And when you move to holdout data, typically we take 10% of the data set, put it on one side, we get the results of the training set, we move the test to the holdout set, and we validate the algorithm's performance. Typically, the performance goes down a bit, but we can tune it so that it generalizes. And when it generalizes, then you have a powerful solution. So questions arise about how applicable it is and how generalizable it is. One of the things that's a problem is if you train an algorithm on a data set and you have a result, the patient's life is going on, the patient is changing. In our context, playing with streaming data, we have a process called active learning where we get the algorithm to keep calibrating itself. So it keeps tuning in and maintaining accuracy as the data set progresses and the individual changes. So you can have adaptive systems, which is what we try and do in the health system anyway. So significance of AI now. In general, there's a growing flood of data and records, telemetry from equipment. Talked a little bit about the electronic record and its problems. One of my colleagues said, we have all the algorithms we need. We're tuning them a little bit. But basically, if you have enough processing speed and enough data capacity, you can just about do anything. Computational power is more and more available and cheaper, and we have networks of fast machines, and industry growth is exponential. And the thing that everybody's noticed recently is what we call large language models. ChatGPT hit the public, and everybody's like, wow, look at this. This will write stuff. It's almost like it thinks. Doesn't think, it's a logic machine, and it does funny things and gets it wrong. But if you want some interesting text that's going to be engaging, that you can read and maybe correct it, a lot of people, including students, have been using ChatGPT to write essays, and institutions have been trying to find out if they've used AI and cheated. So it really is, if you played with it, it's very impressive, and it works in different languages. ChatGPT has now moved to GPT-4, and GPT-4 is quite remarkable. GPT-4 is what has been released to the public is something that can see, hear, write, and draw. So you give it information and you ask it a question. If you get the question right and you give it the correct data, it will have some fantastic solutions. In very logical applications, let's say you want to design a circuit board and you want to write some code to achieve a process. GPT-4 has done that very successfully. It's outperformed expectations. And the iterations of GPT going forward that have not been released are capable of much more. There's a strange word used for large language models, which is hallucinations. They create false information. It's not intentional, they're logic models. And it's, unfortunately for us, been called hallucinations because it's just confusing. They're not hallucinations, they're wrong statements. But that is being addressed. It's not simply you can go in and debug the program. You can't do that. They tried to get rid of that problem, and the whole performance of these large language models collapsed because they're self-developed. They're generatively trained, they browse on information on the internet, they build themselves. So they're looking at different ways to put guardrails around them, make them a bit more protected. So there's risk management, but this is frontier activity. I don't know if I mentioned, but one of my colleagues is using GPT-4 to actually take notes from patient interviews and create a synopsis, a history, and formulate a potential diagnosis and treatment plan. And that's not simply accepted, that's taken as a basis. It's incredibly helpful to develop that kind of thing. At the World Economic Forum, a report came out about the future of digital mental health, which is incredibly positive, perhaps too positive. And I've given the web link up there, and a lot of it's about CBT. And they give a couple of examples of industrial developments, and this is IESO, which works in the UK and the US with the National Health Service and US Medicare. And this is online CBT, digitally driven CBT. There are problems, but it is here. And when you see an organization like the World Economic Forum making that statement, what you see is that leaders around the world have bought in. They've already decided that this is happening. There's no way to stop this train from moving. It's already left the station. I was in Geneva about 10 days ago meeting with the United Nations and the World Health Organization as part of an expert member group on digital health for youth and adolescents. And there's tremendous energy going into these solutions. There are lots of apps around, and potentially they're really good, but it's a bit of a nightmare because they're not regulated. There's an organization that's UK-based called Orca, which is about assessment of the quality of apps. That's providing useful guidelines, and the Canadian Mental Health Commission is also developing guidelines for appropriate use of apps. And my friend and colleague John Torres at Harvard's been doing that work too. So there are a lot of apps around. Most of them are useless. Most of them are not evidence-based. There are some examples here, Wobot, Cogno, and Babylon Health, that have had reasonable press. There's Mood Gym that was developed in Australia a few years ago and was initially free. Now it costs about $60 a year. $60 a year for cognitive behavior therapy is really cheap when you think about the cost of a face-to-face interaction. So this is the changing landscape. The internet's an unregulated space, and governments are going to try and regulate this. At our discussions on the E-Mental Health International Collaborative and in the Geneva meetings, we talked about branding being the thing that's going to make a difference. These apps will be branded with quality. People will vote with their feet. They'll use the apps that work. And it's really important for people in the mental health field to understand the characteristics of apps and how to choose and evaluate them. Or better still, where to go to find a good evaluation of what the app will do. So I mentioned GPT-4. I'm going to say a little bit more about that. GPT-4 is now the most powerful product from API. And it was launched only in March 2023. Everybody knows about this. ChatGPT came out before that. And if you're interested, there are lots of pieces of information on OpenAI's official documentation. And I've given some examples at the bottom. Anybody who wants this slide deck is welcome to have it. So GPT-4 is I'd say the beginning of what large language models are going to do. In the Geneva meetings, there was a vice president from Google there that I won't identify, but it's a VP that's been hired in. The person developed Headspace before, has a really good history in developing digital support for mental health, and now is on the inside of Google. And we had a fascinating conversation about what they actually have that they haven't rolled out yet. So, as they say in the movies, you haven't seen anything yet. It's going to emerge. We also play with chatbots. There's a Canadian program for a resource chatbot for mental health resources across Canada. And this was built without large language models. But now everybody is going to lean into large language models to try to make the resources better and to make the interaction with the client much smoother. Because a lot of the communication gets stuck in that kind of awkward chatbot space where a statement is not understood correctly, there's a response given that's not appropriate, and people get frustrated and they vote with their feet. With language model application here, you're going to see much better, much more effectively resourced chatbot responses in the mental health area. This already developed very well in the marketplace. Mostly if you're looking for supplies or something and you go on a website, there'll be a chatbot. It's like someone's talking to you. It's always a machine. And it's amazing how useful and how effective that is. This is the future. So large, high-dimensional data sets. Machine learning is absolutely necessary to make sense of the data. I would say that I can handle 4 dimensions on a good day, space and time, but we constrain our neuroimaging analyses to a 70 million dimensional space. That's not a big, complex space for machine learning. We do that because of the amount of data storage we need and the amount of time we're willing to wait for the analysis to take place. But the data giants like Google and Apple have massive, massive capacity. And that's one reason why industry is the lead in this. And it's our community's job to indicate what we need and what might work so that we can use the resources they provide. Sometimes people try and build things at home. You can build something in principle, but in the end, unless you're going to start a business, you are never going to be able to maintain and resource and develop one of these entities, however simple it is. You need the resources of the data giants. It's the devil you do, the devil you don't. It's the way it is, and we have to find a way to negotiate with them effectively. Resistance to change. We all know about change and resistance. Digital divide, we were pushed over by COVID, but people like change. They like things to change back to the way they were before they changed. We always want to go back to our familiarity. This is gone. We will never go back to the way it was before. If we do, we'd be in such economically hard circumstances, life in the community would change. It would be really hard. Health priorities. We really need accessible, efficient treatment and care options. I was at a digital health summit with the Atlantic provinces in Canada where the leads of the province, the government leads, they were focusing on building capacity and retaining people. So the province of Nova Scotia decided that American physicians can practice there with no requirements. If you're licensed in the US and you go to Canada, to Nova Scotia, they'll take you on. No questions asked. They're that desperate for physicians. The Canadian system's been quite protective. But it doesn't matter what you do, there'll never be enough psychiatrists. In truth, there'll probably never be enough physicians and never be enough nurses. So as the world grows, we need a different solution, and that solution is digital. Not completely, there's community engagement, but Digital enables community support to grow. It enables people to understand more and be supported. Most of digital health, which we're constantly reviewing, is actually telemedicine. So Australia and New Zealand have a fantastic reputation for digital health. You go to New Zealand, they spend millions and millions of dollars on getting people to answer the telephone. That's not really digital health, but it looks good. They're moving towards digital solutions, but they're not really there yet. Telemedicine is simply remote access, but it's not terribly efficient. Will AI and machine learning provide solutions? I would argue that they really will. Stigma and mental health literacy were mentioned by a few people. And I think Masood mentioned stigma as one of the problems of getting access in one of the plenaries earlier today. With the Mental Health Commission of Canada, we're working on mental health literacy. And what's really important is that includes digital solutions, which will include AI interactions with people, trying to communicate and teach people in communities about mental health. My friend Stan Kuchar, who's a child psychiatrist that some of you may know, retired from psychiatry and is now a member of the Canadian Senate. And Stan is pushing forward the notion that we really need mental health literacy. And it's stigma is like, you tell people about stigma, okay, check the box on stigma. It doesn't change anything because they really don't understand. Stigma disappears when people have knowledge of the lived experience of people with illness. When it's connected to their families, the lights come on. Some people are not that connected or it hasn't happened to them yet. And Stan and one of my young colleagues, Yifeng Wei, who's a professor in my department, are pushing forward with international programs to interact with teachers and kids in the school environment with digital modules, because children spend most of their time in school, 8 hours a day, 5 days a week, more than they do with their families. So that is a really important digital area. Privacy is a big problem. People talk about data privacy and how are we ever going to do this. In Canada, the patient owns data. And things have been changing. The European data rules are quite harsh. The penalties are enormous. How do you manage privacy? I gave a presentation to the board of a bank in Canada. And I said to the bankers, okay, who does internet banking? It's kind of a stupid question to ask bankers, but they all do internet banking. And I said, okay, do you care more about your money or your health data? I don't know anybody that I have met who doesn't care more about their money than their health data. Lack of money is going to affect their health data in some ways anyway. So we do internet banking, it's regulated, there's cybersecurity, it's all good, and we own the data because we do individual banking, it's our money. If you go to the health system in most jurisdictions where they have a developed health system with digital records and you ask for the data, even though the data may be yours, they won't give them to you because they don't know that they're your data. In Canada, the Privacy Commission rules that I own my health data. I could probably get them, but the guy in the street can't. Sorry, you can't have your records. So we need to democratize the system. We need to change things. To meet patient-client needs in this digital space, there's some things that come out of a study of health quality. So in the balloon on the left-hand side, you have these keywords: accessibility, acceptability, appropriateness, effectiveness, efficiency, and safety. Any digital health app, any AI entity that's working in the health system has to be accessible. It has to be acceptable, it has to be appropriate. If it's not effective, there's no point having it. If it's not efficient, there's no point having it. And if it's not safe, it shouldn't be available. Now, all these are basic things about health, but they apply to digital applications. And all of these require access to useful data at the individual patient level. I don't want to go and see a physician or interact with the health system and be treated like the average person for my age and demographic profile. I am a person, I am not an average person. And we have this move towards precision health where we really try and deal with clients or patients as individuals. Tom Insel, who's one of the people that started all the trouble in psychiatry with digital health by supporting RDoc and then going to work for Alphabet, which is Google, he did this because if you talk to Tom, he'll tell you that one of his daughters said, "You've been running an IMH for years and you haven't affected suicide rates in the United States. It's time to do something different." So he was attracted into the data field for that. And that was a big message for a lot of people about moving into doing things differently. But we need access to useful data at the individual patient level. And Tom uses client or patient. He prefers client because patient, because if you're a patient, you get paid for. If you're a client, you may have to pay for yourself. We need capacity to collect, analyze, and store appropriate data. And I'm arguing that we need streaming data capacity because existing health records just will not provide the information we need. This is the thing that came from the Health Quality Council. It's an Alberta enterprise, and they were dimensions of quality along the top: acceptability, accessibility, appropriateness, effectiveness, efficiency, and safety. And they apply to the whole health system. So how can we access and harness AI, and who can do this? One of the things I was reading recently was a piece posted on a chat by a software engineer who said that a lot of the people who code are now wondering if they should change their careers. They're wondering because large language models are coding better than they do. And I talked to the young resident outside about the question that health professionals pick up about, I'm not going to have AI take over my job. I'm a physician. I can't be replaced by a machine. And I said, you know, that's really true, but if you think about all the things you do as a physician or a healthcare worker, there are lots of things you'd rather not do because they're not a good use of your time. And if you had machine support to take interview notes, write histories, make predictions on the basis of big data about what would be the best choice for a patient, you already use tests to guide your clinical judgment. This is another kind of test. So digital can lighten your load and make you more effective so you can make decisions about more patients, and you might be able to spend more time with more severe patients, but provide support for many more patients in the community. And I think that's the way to look at digital rather than, it's a solution-oriented approach, rather than, I'm not having it disrupt my life, this can't replace me. It's not about replacing, it's about cultural change. And who can do this? It's like raising a child. It takes a village to do digital health. You need large databases. Unless you're a real database computing scientist, you've got nothing. So why should you? I remember when molecular biology was born back in the 70s, everybody is rushing to train in molecular biology. It wasn't a good idea because we have molecular biologists for that. We have our jobs, we team with them. It's about a team approach. Clinician involvement is crucial. You need people to translate in that interspace. People who understand the system, people who understand what can be done and offered, people who do the coding. I work with computing scientists who have no idea anything about the health system, but they're great with data. Current concerns, wait times. I imagine that's a problem in Turkey, people going to emergency, having to wait a long time because of capacity. Early identification, early intervention. With AI and machine learning, we'd be able to make predictions about people in their lives. We've done quite a lot of work with suicide prediction. And I think it was Kessler in the US who put something in JAMA Psychiatry saying, it's not really good to do suicide prediction. And he explained that If you had a perfect predictor for suicide, and talking to psychiatrists in the audience, what would you actually do with that? Like, you identify somebody's at suicide risk, you can't take everybody in suicide risk and put them under close supervision or put them in an inpatient setting. So what are you going to do? We don't have the technology to do that. So everybody's going towards predicting suicide risk, and it's a noble thing, and acute management's great. Desmond Tutu is attributed with the statement, why are we pulling people out of the river? Why are we not going up the river to find out who's pushing them in? So in terms of suicide, if you could work out the predictors and you could work out the determinants of suicide, you could go up the river to early childhood and childcare and epigenetics and sort it out that way. That's possible with a machine learning and AI approach, but it requires us to think differently about using the technology. Continuity of care is a real issue. Not everybody can see patients all the time. There's insufficient time. AI and machine learning systems can provide much more support through the community. Access and equity, they're important. Unsung relationship of physical and mental health. We talk about physical health and mental health. When you think about it, if you're physically ill, you're probably going to get stressed out and have some mental health problems. Not everybody, some people are more resilient than others. But the other way around, it works out. There's a space between that's accessible digitally if you record physical and mental health data. And Alan Young this morning was talking about that with the large European depression project that's going on, measuring both and looking at the relationship. And I put in a reference there of one of our dean who's done some work on healthcare utilization in people who are admitted with mental health disorders and looking at more physical health care utilization. So the future's here. Use of internet apps is universal. This is a chatbot from China that was quite amazing. When I was at the G7 meeting and I was the only health speaker, I told them that if you don't watch what's happening in Asia with chatbots, you're going to get left behind. Nobody really listened. It's still miles ahead. This is Tmall Genie, and there's a fantastic thing that was put out at a meeting I was at in Shanghai where an industry VP played the video. This is a bit like Hello Kitty. There's a little chatbot, and it has visual sensors. It can hear, it can speak, and it can see. And there's an old lady in her apartment in Beijing, and the lady wakes up, and Tmall Genie says, "Good morning, how are you?" And the old lady says, "Oh, my back is really hurting me." And the chatbot says, "Did you take your medication today?" "Oh, I think I did." "I didn't see you take your medication. I think you should take your medication." "Well, I never know which medication to use." "Well, why don't you show me the bottles and I'll tell you." "Oh, you don't want the brown pill, you want the blue pill." "Okay, that's good, you've taken it now. What are you going to do today?" "I think I'll go and see my daughter." "What a good idea. Now, it's going to rain today, so you have to remember to take your umbrella. When you leave, would you like me to phone your daughter and let her know you're on your way?" "Okay." I talked to an American physician about this at a meeting in Toronto, and he said, "My mom's really struggling. She's 95. Can I get one?" And I said, "Does your mom speak Mandarin?" "Sorry." This kind of technology can be implemented, and if you caught what I was saying, there's a personal conversation in there. There's a style of engagement. We're talking about a large language model. There's no consciousness here, but there's a style of, what are you going to do today? Oh, it's going to rain. You should take your umbrella. It's engaging. It's better than a pet. It's supportive, it's useful, and it can also monitor the person. I think these have been implemented in Japan, and they're available in China. They're very successful. I wanted to move very quickly into some other simple things. This is my colleague Vincent Adjepong, who is now the head of psychiatry in Nova Scotia. He was a professor at the University of Alberta, and he pioneered supportive text messaging. And this has been used internationally for different reasons. It came out of managing stress in response to wildfire. And the idea was based on some work that was done in Ireland. He was in Dublin before. And simply putting out supportive text messages that are like CBT messages, people actually feel better. It is such a simple manipulation, but if you get it right, randomized controlled trials with real evidence show an increase in wellness, decrease in anxiety, decrease in depressive symptoms, increase in quality of life. So these are programs that are around. It was used during, I'm not going to go through these slides in detail, it was used during COVID and supportive text messaging, measuring responses at 6 weeks and 12 weeks, just giving people access. A proportion of people would respond. Most people in surveys don't respond. It works very effectively. This from 2020. Pilot study got 42,613 people, out of which 8,200 and some responded. The ages here are under 25, 26 to 40, 41 to 60, and over 60. Most people reported their ages. Most are middle-aged people. Outcome measures, perceived stress scale, PHQ, GAD. Just look at the green bars. The green bars indicate success, right? Strongly agree is a green bar. Helps with stress, helps with anxiety, helps with depression, helps with loneliness. These are some selective papers, all from, I think, 2020, showing how it's been implemented. So supportive text messaging is cheap and can be scaled up and spread out massively. My friend John Torres at Harvard's been working, in the middle of COVID, he started a digital clinic thing. And in their Beth Israel clinic, they actually saw patients virtually and did this kind of stuff with surveys and digital navigators. And he's been very productive working on that over the last few years. So with buy-in from patients and clients, I think we need validated individual, personal level, physical and mental health data. We can feed that back to people. We could do an analysis of how you're doing with your own baseline. Streaming data means you get your data today, and it's like the resident I was talking to, I said, your mom probably had a thermometer at home when you were a kid. Deciding whether you were well or ill would depend on your body temperature mainly. Yeah, that's the way it used to be. Now, with streaming data and smart watches, smartphones, you could get lots of different measures, and the algorithm could put together an average response saying you're doing okay, or you should probably get a medical appointment, or you need care now. We're doing this kind of work with remote workers who fly in and fly out to camps. They had a terrible time during COVID. They don't want to go back to remote campsites. And we're asking them how they felt about it and how they'd like to be supported with like an Apple Watch. They're super keen on doing this. We'll never have enough people to do this, but with AI sentinels, we might get it done. So smartphone technology is good for physical measures, and it's good for mental health assessments. Here's an example of what we're doing. 2 measures here because of COVID. This is blood oxygen and heart rate level measures in an Apple Watch. And here's some data. Actually, it's software engineer Tony's data at different times. And the schematic here is we have a mobile app. It goes into a gateway and load balancing, scalable web service, biomarkers being measured, and analysis going on with an AI sentinel. And on the user side, you could have a few things. So if you made your data available to a physician, they could have all the data in its complexity. If it was, let's say, mom and dad who weren't health trained, they could just get, it's a green light, it's a yellow light, it's a red light, go to emergency, don't go to emergency, go to a medic clinic, don't bother, and the baseline can be provided to the physician. Very simple. One of the keys here is that, everybody is scared about data privacy and the problems of that. Those of us who use a smartwatch have already granted permission for our data to be stored, typically in large cloud storage in the US. So we take the data tag from that client, and it gives us the right to pull all the data we want down from the cloud. And we have an agreement with the patient that we won't identify the patient to anyone else. It's not a privacy issue for us because it's what we call secondary analysis. We are not collecting the data. Someone else collected the data, we're looking at it. It changes the whole ethics of how this goes. And it's really democratization because it puts the control entirely in the hands of the client or patient. This is the big problem with health data. The health system collects data and it protects it. And you don't want a violation of that aggregate of data. These streaming data belong to one person. And if you do streaming analysis, you can take summaries, you can take a slice that's 30 days long and delete it every 30 days and keep summaries. You don't have to keep the data. The data are in the cloud in the US. You can use them very practically. So current issues of digital health, equity, ethics, and privacy require democratization of health data ownership, or the system barriers will be immense. There's a barn. It used to have a horse. The gate was open a long time ago. There's no horse. A lot of government agencies are trying to protect the horse that is no longer in the barn. It's already gone. Co-creation is necessary. So when we build apps and systems, we're now talking to people about what they want. It is, in implementation science, absolutely important to talk to clients about what works for them. Otherwise, there won't be buy-in. The features won't be right for people. Everywhere people are talking about co-creation. So we're looking for access, we're looking for data standardization. With streaming apps and data giants, you already have some kind of data standardization. Within the health system and health data, the databases in a given jurisdiction are all different. Integrating data in a geographic area is a nightmare anywhere. No one has a uniform health system. It didn't develop that way. Very quickly, take-home messages. Machine learning is already here in all areas of life. Potential exists for accurate and reliable predictions. There's a flood of apps, most of them aren't good. It's a team sport. Ethics, equity, and privacy are important. Buy-in is necessary. High-tech measures like neuroimaging are really interesting and valuable, but they're not there for health implementation in populations. And most importantly, archival health data are of interest, but streaming data are the future. Thank you.